when it's not a DVT, but I thought this was quite an interesting case to bring up, and it was a very recent case at East Cheshire NHS Trust. So it's important to talk about because I think it influences potentially one of the pitfalls of point of care ultrasound and why it's prudent to check the iliac system as well in presentations of a whole leg swelling. So this is a 16-year-old female presented into A&E with left groin pain for 3 days. On examination, the entire left leg was swollen, different colour compared to the right. Recently started on the oral contraceptive pill, and a point of care ultrasound in our ED department showed that there was a clot in the upper left femoral vein. So I'm going to ask a question at this point. How would you manage this? What would you do in the A&E setting going forward? I'll give you a minute just to write something on the chat.
In the question and answers, because the chat is disabled.
Oh, there's a chat disabled. So in the question and answers, sorry.
We'll start treatment dose delta pallid.
Okay.
Yeah.
Anything else?
Is the leg good perfused? Question.
Yeah. So I believe in this case it was well perfused. Yeah.
Somebody said depends if they had arterial pulses still. Does the color change reflect phlegmasia CD?
So there are two cases, but in this case, yes, the patient leg is blue. Yeah. So the patient leg was blue. Anything else?
So on ultrasound, we confirmed the point of care ultrasound findings. So the left common femoral vein was indeed occluded. So tracking down the leg, we can see that the femoral vein and deep femoral veins are occluded. The distal superficial femoral vein is occluded. Yeah, and usually in this case, because we expect most DVTs to propagate up from the calf, the popliteal vein was actually patent. So our protocols in the ultrasound department will go up and try and find where this clot's got to. So we went and did a scan of the tummy. You can see that the external iliac vein is occluded, as is the left common iliac vein. In transverse, some quite nice images here. We can see in the image on the left that the right and left common iliac arteries are patent. You can see that there's no flow in the left common iliac vein as it's going over the lumbar spine, and it's passing across underneath the right common iliac artery. Again, it's probably slightly better image on the top right. It was at this point when I did the scan, I wasn't sure if I could see a slight filling defect in the vena cava. And anyway, the patient went on for a CT. You can see on the image on the left that there was no flow in the left common iliac vein, and you can see on the right its relation compared to the iliac arteries. Again, you can see that the IVC is patent in the image on the left. You can see the right and left common iliac arteries here. And then this would be the confluence of the left common iliac arteries that's coming into the right, so into the IVC. The bottom right image, you can see that the right common iliac vein is patent and the left is not present, there's no flow. So CT reports confirmed the ultrasound findings. The only thing that they went further is that they queried that it may be secondary to May-Thurner syndrome. At this point, the patient was transferred to the nearest vascular centre for assessment. So, causes and presentations. So, well, it's an anatomical variant. May-Thurner syndrome is an anatomical variant where the right common iliac artery overlies and presses the left common iliac vein against the lumbar spine. This leads to an increased risk of left-sided iliofemoral DVTs, typically young adults. So, one of the seminal reviews by Crockett and Thomas reports an average age of 23 years. Half of those patients were below 20. They commonly present with whole leg swelling. It's quite common after surgery. And the key things for us, I think, are during pregnancy and during the postpartum period. Obviously, it's more prevalent in females. So if you had a patient presenting in A&E and you couldn't see clot burden in the left femoral vein, say, in the first point of compression, what we would do in the ultrasound department as part of the vascular team is we take common femoral spectral waveforms, and we're looking for a Valsalva response. I guess in cases like this, it may be prudent to refer to the vascular team to do that assessment and have a look at the iliac veins. So treatment, so patients can respond poorly to conservative anticoagulation alone due to continued compression, mechanical pressure. Some centres are going towards an endovascular treatment with catheter-directed thrombolysis or mechanical thrombectomy. Patients, if the clot burden isn't removed sufficiently, they might go up for follow-up venography and a venous stenosis may undergo balloon angioplasty with or without stent placement. So in this case, the risks of mechanical thrombectomy were discussed with the patient and the levels of thrombosis after stent placement. Because she was a young female and they were unsure if she was going to go on to have pregnancies in the future, I think they decided to manage the patient conservatively with treatment dose rivaroxaban and graduated compression stockings for follow-up review at 3 months and 6 months. So she's just had that 3-month review and she's responding quite well. So this is one area for discussion. It was brought up at one of the venous symposiums at Manchester last week. So current NICE guidance doesn't really give us much on how to manage these patients with regards to mechanical intervention or thrombolysis. There's a recent cost-effectiveness study that was in September this year, and it's showing that actually mechanical thrombectomy might be more cost-effective over a lifetime when compared to anticoagulation therapy alone. There's a new study which is in process, the DeFine study. It's supposed to be the first randomized controlled trial to evaluate mechanical thrombectomy alone against anticoagulation. So we're awaiting the results on that. And there were 2 studies looking at catheter-directed thrombolysis. So there's a Cavant trial and the ATTRACT trial. So the initial findings of the Cavant trial, randomized controlled trial, showed that after 2 years, there was benefit for catheter-directed thrombolysis, but this extended at 5 years. The 71% of the patients were developing post-thrombotic syndrome, which is a major complication of iliofemoral DVTs, when compared to the patients who underwent catheter-directed thrombolysis. And the reason why I bring this up is it's probably going to influence what our ultrasound protocols are going to do in the future. So you can see that we went down the leg a bit further with this one to show that the popliteal vein was clear. That gives us an access site for doing mechanical interventions or thrombolytic therapies. So it may well be in the future that these studies push us towards a different way of managing and dealing with these patients. This is something which has just been set up, so it's the European Venous Registry. So it aims to collect real-world data over a 10-year period, started this year, and it's on management of patients with iliofemoral or IVC, deep venous disease, both acute and chronic.